I am Dr. SUPRIYA SARKAR, Professor and Head, Respiratory Medicine, College of Medicine and Sagore Dutta Hospital. Today I will discuss the analysis of arterial blood gas. Now, junior doctors are often confused whether they should go to the long, cumbersome way of clinical medicine or they should choose the modern technologies. And I will answer this question after the end of my talk. Now, first part is to verify ABG reports. ABG reports can be verified by a formula. This is 80 minus X is equal to 24 into PCO2 by bicarbonate, where X is the first two digits after decimal. As for example, if pH is 7.364, then X will be 36. And after that, we have to differentiate between arterial and venous blood, and that can easily be done by comparing the SaO2 found in ABG reports and SpO2. We can measure it by pulse oximetry. After verification, we know that our main aim in respiratory medicine is hypoxia. And there is an interchangeable term, hypoxia and hypoxemia. There is some difference. I am not going into that. So hypoxemia is defined as PaO2 less than 80 millimeter of mercury. It can be mild when PaO2 between 60 to 79 millimeter of mercury, moderate between 40 to 59 millimeter of mercury, severe less than 40 millimeter of mercury. Now, there is the oxygen dissociation curve, and it looks like that. So above 60 millimeter PaO2 level, the saturation of more than 90% is reached. But beyond that, there is flattening of the curve. So if we increase the PaO2 level more than that, there will be little change in the saturation. But below this 60, there is a sharp fall in the oxygen saturation. We know that oxygen transport to tissue depends on two factors. One is the cardiac output, another is the oxygen content of blood. And oxygen content of blood is predominantly determined by the oxygen saturation. And from this formula, you can see the contribution by PaO2 is very less. So this 60 millimeter of mercury is taken as a unit for the definition of respiratory failure. Now, hypoxia occurs when there is a decreased FiO2, and it can occur in high altitude or if oxygen supply is interrupted in hospital. This is the rare occasions, we should not discuss them. Then the diffusion abnormality. We know that during the pulmonary capillary passage, in 1/3 of their journey, the diffusion process is complete. So there is 2/3 reserve. So even with the diffusion abnormalities, there is little chance of hypoxia, unless patient is doing exercise, thereby the cardiac cycle is decreased. So in case of diffusion abnormality, hypoxia only occurs during exercise, not at rest. So it is also of less importance. Third is hypoventilation, and hypoventilation is identified by associated hypercapnia. Fourth is ventilation perfusion mismatch, and that can be identified as it is corrected by giving oxygen. So ventilation perfusion mismatch is the commonest cause of hypoxia. So in wards in ICU, we are giving oxygen, and this high ventilation perfusion mismatch will be corrected. Then there is right to left shunt, like AV malformation, and in those cases, it is not corrected by giving oxygen. Now, coming to hypoventilation, we know that the PaCO2 level is inversely proportionate to alveolar ventilation. And PaCO2 level, we know that this is 40 plus minus 5. normal conditions. And so in hypoventilation, carbon dioxide will be increased, or in hyperventilation, carbon dioxide will be decreased. Now in hypoxia, we have to look for three things. Number one is the carbon dioxide level to determine whether there is hypoventilation or hyperventilation. Then the alveolar arterial oxygen gradient to see whether the defect is in the lung or outside. And lastly, and most important, PaO to FiO2 ratio. If it is less than 300, we should diagnose it as ARDS if other parameters are met. And pH, we know that when pH is less, it is called alkalosis. When pH is low, it is called acidosis. pH varies when pH is increased, bicarbonate is increased, pH also increased. But with carbon dioxide, pH varies inversely. So when carbon dioxide level increases, pH falls. So in bicarbonate, if the bicarbonate is the main pathological event, then if bicarbonate increases, it is called metabolic alkalosis. If bicarbonate is less, it is metabolic acidosis. On the other hand, if carbon dioxide level increases, it is a respiratory acidosis. And when carbon dioxide falls, it is respiratory alkalosis. Next step is the compensation. We know that lung responds very rapidly, but they are less effective. So in case of metabolic alkalosis, when bicarbonate is increased, the carbon dioxide will increase. And on the other hand, in metabolic acidosis, when bicarbonate falls, carbon dioxide level as a compensation also falls. Please note here that for compensation, the bicarbonate and carbon dioxide moves in the same direction. And the carbon dioxide, that is a simple formula for finding bicarbonate level between 10 to 40 millimole per liter. PaCO2 is equal to bicarbonate plus 50. And this formula will be effective between 10 to 40 millimole or per liter bicarbonate level. On the other hand, kidney are lazy organ, but may be more effective. So in case of the respiratory acidosis, in early stage, there is 1 millimole per liter increase. In the late stage, there is 4 millimole per liter increase of bicarbonate level. On the other hand, in case of respiratory alkalosis, in early stage, there is 2 millimole per liter decrease. And in case of chronic cases, it is 0.3 millimole per liter. So that is 1, 2, 3, 4 formula for assessing the bicarbonate changes during respiratory events. Now, some examples taken from life. Now, in COVID era, let me start with a COVID patient. Now, COVID RT-PCR positive man presented with dyspnea and hypoxia. And his ABGs shows there is alkalosis and hypoxia, and PaO2 by FiO2 ratio is 94.44. There is hypoxia, and as a result of hypoxia, there is hyperventilation. As a result, carbon dioxide is low, so there is respiratory alkalosis. But what happens to the bicarbonate level? It moves on the opposite direction. When carbon dioxide is falling, the bicarbonate is on the increased side. So there should be a dual pathology. So bicarbonate that is associated metabolic alkalosis. So we should search for the common causes of metabolic alkalosis, like vomiting, like dehydration, like metabolic disturbance, etc. They are the common causes we should look for. In this patient, the CT. Now, CT, the common find is the peripheral ground glass and consolidation. The difference between ground glass and consolidation, in case of consolidation, you cannot see the underlying structure, but in case of ground glass, you can see the underlying structure like that. But more important than that is that the vessels, it is called vascular tree invert sign, the tree invert within this ground glass opacity, and that is more specific for COVID infections. Another specific sign for COVID infection is bullseye sign. Now this ABG, that is pH is in the lower side. There is normal PaO2 and it is almost near normal. But if you go to the history, it is a COVID RT-PCR positive 55-year man with poorly controlled diabetes. And patient was on 6 liters per minute oxygen with through nasal prongs. So it's calculated FiO2 is 0.44 and PaO2 FiO2 ratio is 145. So it is not a normal ABG, though it apparently looks like a normal. But in case of COVID patients, what we expect? We expect respiratory alkalosis. But here it is, the pH is on the acidotic side. And you can see the bicarbonate is low. So our diagnosis should be respiratory alkalosis with metabolic acidosis. A 18-year girl with Guillain-Barré syndrome. What we expect? We expect ventilatory failure. So there is respiratory acidosis, pH 7.21, and carbon dioxide level is high, 70 millimeter mercury. So 30 millimeter more than normal. And bicarbonate 32. What we are expecting in this patient, in case of acute setup, there should be 3 millimole per liter increase in the bicarbonate level. Now, the bicarbonate level is 32, so it is more than that. So if the condition is acute, then there should be respiratory acidosis along with metabolic alkalosis. But if the condition is chronic, we do not know the history, then we expect 12 millimole per liter increase, 1 and 4, 1, 2, 3, 4 in the 1, 2, 3, 4 formula. So that we expect 12 millimole per liter oxygen increase in the bicarbonate level. It is less than that. So there should be the respiratory acidosis along with metabolic acidosis, and her pH also in favor of the second conditions. So history is very important. Duration of illness is very important for assessing the ABG report. But more than that, what is important here is the alveolar arterial oxygen gradient. And her oxygen gradient is 230 millimole per millimeter of mercury. And so it should be normal in Guillain-Barré syndrome. So it indicates the increase alveolar arterial oxygen gradient increase. There should be some underlying lung disease. It may be in the form of infection. It may be in the form of atelectasis. So we have to correct that. So when the patient recovered the Guillain-Barré from his her neurological conditions, we can win her out from the ventilation. If we do not address this alveolar artery increase alveolar arterial oxygen gradient, then we cannot do that. A 20-year girl presented with acute onset respiratory distress following vivax malaria. Now, here pH is alkalosic. There is hypoxia with PaO2 FiO2 ratio 182. And her X-ray shows bilateral lung infiltration without cardiomegaly. So we diagnosed this case as ARDS. And we put her in mechanical ventilation. But we can extubate her by 48 hours. That made us thinking, in ARDS, that is not possible. And if we carefully look at the X-ray, there is bilateral pleural effusion. So echocardiography was done, and that shows tight mitral stenosis. It may be this pulmonary edema may be a combination of both factors. Do not know actually. A 16-year girl with irregularly treated asthma. In case of asthma, what we are expecting that patient will hyperventilate. And as a result, we are expecting respiratory alkalosis. and carbon dioxide level should be low. If even normal carbon dioxide level in case of asthma is a danger sign. Her ABG report shows there is acidosis and carbon dioxide is 50 millimeter of mercury. So there is respiratory acidosis. Respiratory acidosis occurs in late stage of asthma in which there is muscle fatigue. And in this case, patient was put on invasive ventilation. But next day, this should be our ideal situation, but next day, patient deteriorated and patient was referred to Kolkata. ABG was more acidotic and carbon dioxide level increases and patient condition deteriorated. So in critical condition, patient was transferred to Kolkata and her X-ray and clinical examination shows there are subcutaneous emphysema. Follow-up X-ray here, it shows there are subcutaneous emphysema along with there are deep sulcus signs. The costopenic angles are deep. It is called deep sulcus sign. So we introduce in intercostal tube both sides and we can extubate her by 3 days and patient was discharged by 10 days after removal of the intercostal tube. Now VQ mismatch. It is very important, as I have told you, that VQ mismatch is the commonest cause of hypoxia. So in VQ mismatch, there are some areas where ventilation is less than perfusion. Here, deoxygenated blood comes out. On the other hand, there are areas where ventilation is more than perfusion. Here, oxygenated blood comes out. But due to peculiarity of oxygen dissociation curve, this part cannot compensate this part. So ultimately, there is deoxygenated blood that reaches the systemic circulation. But more important than that, in this area, it acts as a dead space. We know that minute ventilation is equal to alveolar ventilation plus dead space ventilation. And as dead space increases, alveolar ventilation decreases. And as alveolar ventilation decreases, carbon dioxide level rises. So in case of COPD, what we expect? We expect hypoxia, we expect raised carbon dioxide level, and as it is a chronic process, bicarbonate will increase, and as a result, pH will be near normal level. Now, a patient with acute exacerbation of COPD, here the pH is less. We do not know what is his baseline carbon dioxide and bicarbonate level. So in this case, conditions of acute on chronic respiratory failure, pH is very important indicator. So there is acidosis, and as pH is less than 7.164, patient was put on invasive ventilation. On the next day, this is his ABG report. And if we consider this in isolation, it may be look as metabolic alkalosis. But if we compare with the previous one, there's remarkable pH changes. But that pH change cannot be explained by bicarbonate change. So it cannot be a metabolic disorder. It is there is a fall of carbon dioxide level, and it is due to, so it can be explained by this pH change can be only be explained by carbon dioxide changes. And if you compare with the normal condition, from normal condition, the carbon dioxide level decreases. So it is respiratory acidosis, respiratory decreases, acidosis, alkalosis over respiratory acidosis, because there is a fall of carbon dioxide level from his expected normal level. So it is respiratory alkalosis over the chronic respiratory acidosis. And why this happens within 1 day? Because of the high minute ventilation set in the ventilation. And in high minute ventilation, so what we should do? We should reduce respiratory rate, tidal volume, or both. And thereby we can decreases the minute ventilation, and thereby we correct this metabolic disorder. And this is a common event. Now going to the metabolic acid-base disturbance part. Now this is a 60-year man with dyspnea, and ABG shows there is acidosis and bicarbonate is less, so it is metabolic acidosis. And there are additional data shows that it is uremic acidosis. Another patient, a 32-year man with insulin-dependent diabetic mellitus, and again his ABG shows acidosis, and acidosis is due to the bicarbonate fall. And carbon dioxide also, there is less carbon dioxide is due to the compensatory mechanism. And the respiratory acidosis can be divided into the high anion gap and normal anion gap metabolic acidosis. But for the diagnosis of diabetic ketoacidosis or some uremic ketoacidosis, we do not need ABG. For respiratory specialist, there are few occasions in which the metabolic disorders are important. I am giving two examples. A 64-year man smoker presented with dyspnea, and his ABG shows alkalosis, and this alkalosis is due to rise of bicarbonate level, so it is metabolic alkalosis. The common cause of metabolic alkalosis are the vomiting, diuretics, low chloride, low magnesium, and they can be easily distinguished and they can be easily managed. But in this patient, there are triads of metabolic alkalosis, hyperglycemia, and hypokalemia that indicates the mineralocorticoid excess syndrome. His X-ray was normal, but CT shows there is a nodular lesion in the right upper lobe, and that was PET positive. The CT guided FNSC suggestive of small cell lung cancer. So it is a small cell lung cancer with paraneoplastic syndrome of mineralocorticoid excess. A second case, a 60-year man with COPD and diabetes on mechanical ventilation. And his pH ABG was normal on the third day, but due to some other reason, the extubation cannot be done. On the seventh day, the ABG shows acidosis, and this acidosis is due to fall of bicarbonate level from 40 to 27. As patient was diabetic, so we are thinking of the diabetic ketoacidosis. His urine shows ketone body 1+, but CBG shows was 136 milligram per dl. So it may not be diabetic ketoacidosis, but it is dietary ketoacidosis. We know that in ICU, the nutrition is often a very neglected subject. So it is maybe due to dietary ketoacidosis. And we lost the patient on that night. It is so serious condition. So if we get a ABG report, the first thing is to confirm the arterial sample, then assess the validity of the report. After that, we should analyze the PaO2 level to assess whether there is a respiratory failure or not. If respiratory failure is there, we should look for three things: PaCO2, PaO2 FiO2 ratio, and alveolar arterial oxygen gradient. After that, we should analyze pH to look for whether it is acidosis or alkalosis. Then analyze carbon dioxide, whether it is to assess whether it is a respiratory disorders. Then assess for bicarbonate to assess whether it is a metabolic disorder. And when metabolic disorder is present, then we have to calculate anemia and base excess based deficits, then assess for compensation for bicarbonate. In the respiratory disorder, we know that bicarbonate plus 15. PaCO2 is bicarbonate plus 15. But in case of respiratory disorder, we have 1, 2, 3, 4 formula, and that can be applied. After that, the most important part is the clinical correlation and application. The clinical history, the clinical setting is very important. Another thing is very important is compare the ABG with the earlier one. It should not be looked as in isolation. It should be looked along with a clinical setting and previous ABG. Then we can understand what to do with that ABG report. And most important for any laboratory methods is that do not treat ABG report, treat the patient. With this, thank you. Now, last thing was important, my question. That was whether we should go for clinical medicine or modern technology. My answer will be, if we can converge them, then you will be a good doctor. With this, thank you.